Welcome to day 2 of Consumer Action's Health is Wealth convening. We'll begin soon, but first, a few housekeeping items. First, from the control panel to the right of your screen, you may use the Q&A section to submit questions. Time permitting, we'll field some questions at the end of the panel. In the control panel, you'll also find today's program under Handouts. GoToWebinar offers multiple view options. To select your preferred view mode, from the top menu bar, you may select to view everyone or the person speaking. Finally, today's event is being recorded and will be made available for future viewing. Now I'd like to introduce you to today's MC, consumer reporter Herb Weisbaum. Herb is one of America's top consumer experts. He's been protecting consumers for nearly 40 years. Herb is the consumer reporter at KOMO Radio in Seattle and a contributing editor at checkbook.org. Over the years, he's been known to many as Consumer Man. During his distinguished career, Herb has covered the consumer beat for NBC News Digital, NBC's Today Show, and CBS News. He's exposed everything from quack medications to bogus investments. A 5-time Emmy Award winner, Herb's dedication to protecting consumers has been honored by the Consumer Federation of America, United Press International, and the Society of Professional Journalists. He also received Consumer Action's Consumer Excellence Award in 2008. Please join me now in welcoming Herb.
Good morning. Greetings from the Seattle, Washington area, or good afternoon if you're on the East Coast. Nice to have you with us again today. Got a very interesting topic, telemedicine and telehealth, and some great panelists to talk to you. I just want to let you know that if for any reason you hear a little barking going on in the background, I'm coming to you, as you see, from my home office, and Crinkle the Wonder Dog is here next to me. So if for any reason you hear anything, just watch it. That's who it is. Wear your mask. You always have to wear your mask right now. Okay, so as I said, we are talking about telemedicine. It has been around, as I'm sure you're aware, for years now, but it's sure got a boost in the arm from the COVID pandemic, as did everything that is virtual in our world these days. Is telemedicine good? Is it here to stay? Will it expand? Or will it go back to normal once the COVID vaccine is widely available sometime next year? Those are just some of the questions we're going to explore today. Before we get started, I happen to spot a brand new survey that came out on Monday on telemedicine. It was a survey of 500 executives in the healthcare industry, and it found that the switch to telemedicine necessitated by the pandemic has been a largely positive one, and the majority said at least some of the changes they believed would be permanent. Now, according to a report in healthcarenews.com, the survey, which was conducted by a Boston marketing agency, Boston Digital, found that 57% of executives said telehealth had increased the quality of patient care, 57%. But the results weren't all rosy. About a quarter said that it had no impact on the quality of healthcare at all, and 15% said it had decreased the quality of healthcare. Some of the things we'll be talking about today. Before I introduce our panelists, I want you to look at a little video, if you would, to make sure we all understand what telemedicine is and how it works. This was produced by the folks at Johns Hopkins. Take a look. All right, so I should be back on again. So that's just an idea of what we're talking about. And I want to introduce our panelists right now so they can turn their cameras on, and I'll introduce all of them to you, and then we'll get started with the first round of questioning. First of all, we have, hello everybody, we have Dr. Kumar Dharmarajan. He's a cardiologist, geriatrician, and chief scientific officer at Clover Health, a Medicare Advantage company. And he's responsible for the oversight of Clover's clinical programs, including house calls to frail older adults and research collaborations with industry and academic partners. He also oversees Clover's telehealth engagement with its members. Next, we have Kathy Wibberly, director of the Mid-Atlantic Telehealth Resource Center. Telehealth Resource Center is a federally funded program to assist with telehealth program development and sustainability to increase access to quality healthcare for rural and other underserved populations. Dr. Wibberly is also Director of Research for the Karen S. Rubin Center for Telehealth and Assistant Professor of Public Health Sciences at the University of Virginia School of Medicine. That is a lot to get on a business card. And Sarah Green, Vice President of Commercialization for NextGen Healthcare, an electronic health records company. Sarah is responsible for the operations of NextGen's telehealth patient experience platform. And until recently, Sarah was the Chief Executive Officer of Auto Health, a telehealth company. And finally, Pam Dixon, founder and executive director of the nonprofit World Privacy Forum. Pam has been a leading voice on health privacy and data protection issues, known internationally for her pioneering research into medical identity theft, data brokers, preventive analytics, and online privacy. And in recent weeks, she has co-authored a report on health records, or HIPAA privacy and security rules, and issues that we'll be touching upon a little bit later. So thank you all for joining us. And we have a lot to get going. So Dr. Dharmarajan, let me start with you. How do you believe this is working, and how has this allowed you to stay in touch with your patients and patients to stay in touch with their physicians during COVID, when in many cases we were being discouraged, still in many cases, from going to the hospital?
I think that's a great question. In many cases, actually, I think telehealth was a lifesaver in terms of member access to care. So Clover is a Medicare Advantage plan, so we are primarily provide health insurance to older adults. Most of our members are in New Jersey, and New Jersey and New York, as many people know, were one of the early epicenters for COVID. And so at the peak of COVID in New Jersey, I would say that was April, May, 35% of outpatient practices that we're seeing our members shutter. Either some of them are still closed and some of them were temporarily closed. And what we tried to do immediately was, within a few days, actually build the telehealth platform that providers could use across the state of New Jersey and other places in the United States where we have members to provide care to members. And so literally 35% of practices were closed. I think the key, though, for telehealth is meeting patients, health plan members, older adults, where they are, so that they're able to engage in the platforms. And then there being a payment structure from the government, private insurance, et cetera, to support that. And that might mean telehealth without video, because a lot of our poorer members, they don't have smartphones. So that Johns Hopkins video, one of the doctors there said, most people have a smartphone or tablet. I can tell you most of our health plan members don't have a smartphone or tablet. So how do they engage with telehealth? How do we create financial incentives for providers to provide care? And those folks are the most vulnerable many a time. They live in areas with high area deprivation, they're less technically savvy, et cetera, but they have a ton of medical problems just like everybody else. And so we have to figure out ways to make sure the people who need it most get that care they need.
As we discussed yesterday, a huge percentage, I believe it was 45% of African American and Latino homes don't have either access to good broadband or broadband at all. So it is not, we're not there yet where everybody is totally plugged in, which brings me to Dr. Wibberly, which is you're dealing with a lot of the rural folks who may not even have a decent internet access, right? You have to turn your mic on, doctor. Yeah, you're muted. Oh, we don't hear Dr. Wibberly. Did you unmute yourself? Okay, let's move on. Maybe we can work that out.
Okay, there we go.
Oh.
I was not able to unmute myself. I kept clicking on the button. It said you're muted by your organizer.
It's a telemedicine. If you're trying to talk to your doctor. sign language. And okay, so I mean, I assume that that is a problem that you deal with, that people don't even have access to.
We do. Yeah, so we have really had to work on the broadband issue, especially in the rural and underserved areas. And um, it's two issues. One is people who might have devices but may not have internet access in the home. So they would have to go to a workplace or a free Wi-Fi area, which is always not always the best for privacy and security. But I think we also have the issue with devices. And so there's a really interesting organization, a group of Yale students that started up a nonprofit called Telehealth for Seniors that actually is trying to address that issue. And they are hitting quite a few states around the country now and expanding. So I think there are definitely efforts looking at trying to mitigate that issue.
Is there a difference, do you believe, between the benefit if it's telehealth through telephone or telehealth through the entire video process? Is there a difference?
Absolutely. I think so much of our communication is nonverbal. And so, being able to see your body language and my being able to see what's going on, and especially if you're a clinician, being able to see even the pupils dilated or, whether someone is, having skin flush issues or, those are all diagnostic things. And if you can't see that, you're definitely missing a lot of information.
Sarah, where do you think we're headed with all of this?
I don't think it's going to go back to the way that it was before. Telemedicine has had a long list of benefits for a long time, but it's also had a long list of barriers, and those are being removed to the extent of reimbursement, access, of course, as we're talking about. But I think that there are benefits both on the provider side, but certainly on the patient side. So I think this is a trend that will only continue.
And dealing with anything electronic, Pam, we of course have privacy issues, and that's your whole area. We'll get into it more in depth in a while, but what do you just see off the top line of privacy issues for all of this?
Yeah, so for telehealth, it's really an interesting topic because telehealth prior to the pandemic did have a lot of barriers. When the pandemic started, the Department of Health and Human Services put out something called a HIPAA waiver, which is health geek speak for, it was a temporary rule, actually. It's still in place because the pandemic has gone on a long time, obviously. But it facilitated telehealth happening without privacy enforcement and security enforcement actions from HHS for something that was set up rapidly and maybe not with all of the risk assessments that you would usually have to conduct for use if you're a healthcare provider. So for example, Dr. Wibberly and Dr. Kumar and the other physicians online would have had those barriers cleared. And there are a lot of issues associated with what's called the HIPAA telehealth waiver. So right now, the changes are not permanent. They're just an emergency measure that it's continuing because of the pandemic. But I think that we will have to find solutions because it has met an absolutely huge need. And we heard from a lot of doctors when we were interviewing providers to find out what they thought about this. And they said one of the biggest things was the billing. And of course, this was not something I really specialized in, but I note it and note that there's going to have to be a lot of work to make this permanent.
Well, let's bring up that issue. Any of the three other panelists, go jump in if you would, but I was told that at one point there wasn't the same reimbursement for telemedicine, so therefore many doctors didn't want to do it. They wanted to have you come in. Where do we stand with reimbursement, and how's that going to play into all this? Dr. Kumar, doctor, we start with you.
Sure. So I think as Pam said, with the CMS and HHS emergency declarations around COVID, a lot of the restrictions around telehealth have been lifted. So there have been what are called originating site requirements and other sort of requirements to say, historically, like you cannot, let's say, provide telehealth in a situation where the recipient is in an area that's not considered rural or underserved in various respects, or the telehealth had to be provided within an ongoing relationship, or maybe couldn't be provided across state lines. So there've been a number of relaxations with coronavirus. And frankly, I think they're welcome. I think Pam, was describing some of the HIPAA waiver. I have to tell you, that has been critical to the idea of meeting patients where they are because, and Pam, I think you'll probably have strong opinions on this. In many cases, patients can't manage the telehealth platform that is the HIPAA compliant platform used by your hospital or health system or health plan. Even something as sending them a text where you're like, you just need to click the link in this text and it's going to launch that program in your smart device. Just that is a barrier. And so we found that in certain cases, we're like, oh, you use WhatsApp? Perfect. We'll do this through WhatsApp. Oh, use FaceTime? Oh, Google Duo, Facebook Messenger, this, that, Zoom. If they're familiar with a platform and you're not physically next to them to train them in something new, allowing them to use what they're comfortable with is, to me, the best way of maximizing access to care. There may be other, I guess, privacy and other issues. I'm sure, Pam, you have an opinion on that. But to me, in all of this, that was the most helpful, really allowing a telehealth provider to use more than a, telehealth platform that's in their electronic health record or what their health system cares for, because for many patients, that's been very difficult to manage.
Can I respond to that real quickly?
Go ahead.
Okay. So yeah, I think you're exactly right, Dr. Kumar. And the thing that's really interesting about the relaxing of the rules from the Department of Health and Human Services is that it allowed kind of non-HIPAA platforms such as WhatsApp and Zoom, Skype, FaceTime on Apple iPhones, et cetera, et cetera. I mean, if you can think of a video platform, I mean, the rules for creating HIPAA compliant, telemedicine that complied with all of the rules of HIPAA, it's actually it's a very significant undertaking. But with the waiver, what happened is it opened it all up. So really, of the waivers, this is the waiver that made the most sense. There were some waivers that are still in place, which we won't even go there, but they were problematic. This one wasn't. I do think that one of the big privacy, there's a couple of key privacy risks that we're encountering from patients who contact us. One is if they are having to go to a public place in order to make the contact because of a lack of broadband. That's something that we're going to have to all figure out. But the second issue is that when this pandemic ends and when we find a way to negotiate making this permanent, and it will have to be a deep negotiation and very formal one at that, there's going to be a lot of non-healthcare telehealth providers that were ad hoc. So for example, WhatsApp or even Facebook, communications through various ways. Just the fact of a communications with a doctor's office has completely different protections there than under a healthcare provider's platform. So it's going to be really important to do cleanup after the fact.
Dr. Wibberly, could you just talk at all about the reimbursement situation, how that works with telemedicine right now?
Yeah, so I think with the pandemic, it has simplified what is and will be, again, a very complex system. And part of the complexity is that each payer has its own policy, and each state Medicaid program has its own policy, and each state private payer set of programs has its own policies. And so the challenge is that providers, you want to be able to say, as a patient walks in the door, yes, you will be reimbursed for that. It doesn't matter what service, it doesn't matter where you are, and that's not the case. And so, as was mentioned with Medicare, you had all these different restrictions. So you had geographic restrictions, you had facility restrictions, you had the type of provider restrictions, you also had restrictions on the types of services that provider could provide. Whereas with Medicaid, each state has a different set of Medicaid policies. And so for one state Medicaid program, it might reimburse for a number of things without restrictions, whereas for another state, you would have a whole set of restrictions. And then with private payers, you have some states that have basically what's called parity legislation, basically saying that private payers cannot deny coverage because it's provided by telehealth. but some states do not have that. And so you have this whole landscape that is different. And so every time a patient walks in the door or calls or contacts you, you have to navigate the, will they pay for this service? Will they not pay for the service? And that has been a barrier to people saying we want to do this, as part of our practice. I think the other part is the telephone piece. And so what we saw with the pandemic is that many payers have paid either at the same rate or just at a slightly lower rate for telephone care as opposed to video care. Prior to the pandemic, telephone care was not reimbursed at all.
Somebody should print up a bumper sticker that says healthcare, nothing is ever easy.
Absolutely.
That's us.
We're talking about the access online, but also equipment is a problem, and you have a story to share about how you're trying to make equipment available to people.
That was to me.
Yeah.
Yeah. So I come from the technology side. So Pam, I am intimately familiar with what you said about how difficult it is to make a fully HIPAA compliant platform. So I can speak to our customer experiences. It is challenging to get the right access for the right patients at the right time. And we have customers who have been very creative in that approach. We have one group who is in Florida, who's also a Medicare Advantage program, and they have had their staff who would otherwise have been furloughed during the pandemic drive iPads to the patients. You sanitize them, they're wearing masks, and connect on their behalf to the provider who's back in the clinic. But there are a lot of ways to get creative about that type of connection between patients and providers. But Dr. Wibberly, to your point, I mean, I think one of the barriers is the complexity. To that extent, we have some of our organizations just do cash pay. They have chosen not to navigate all of that complexity, even during the pandemic, as things have been very relaxed. And I still think that is a really good option because you're still connecting with your provider. And there are a lot of direct-to-consumer platforms out there where you can connect to just whatever provider is available to pick up the phone next. But to have your provider where you already have the established relationship, where they have your medical records sitting in front of them, you don't have to share that information through the internet, Pam. I think that's a really good place to be. And it's a really nice option for those who choose not to navigate the never-ending complexity of medical reimbursement, for sure.
Well, being here in the Northwest, we have thankfully great digital access. I've done telemedicine several times. It was basically for a med check kind of situation. The doctor was just checking how I was doing with my meds. I found it to be fine. It was no problem whatsoever. Wouldn't be as comfortable for me if it was a first visit for a doctor. And I don't know if a doctor would even do a first visit virtually, but so I don't know how I ever would have done PT virtually. That would have been a major challenge. But Dr. Dharmarajan, could you talk a little bit about that, about how, can it work for a first visit? Or is it basically follow-up care, or where do we stand with where we are right now?
Yeah, I think it can work for both first and follow-up visits. I think it depends on the content of that visit. So, and really on some level, the comfort of the patient with the platform. So I think visits that rely significantly on history taking, that can be done perfectly well over a telehealth platform. I think where it gets dicier, and there are technologies that can help there, but they're not disseminated broadly. If you really needed to examine that patient, you really needed to listen to the heart and lungs. And again, there are remote ways of doing this. It's just not, the patient may not have access to a remote stethoscope that they can put on their chest and you can hear it from where you are. Or if you have a wound, you really need to look closely at it. It's just not as good in that situation. So I do think that's something we're grappling with clinically. At Clover, we run a number of different clinical programs, and we're trying to find that sweet spot because we know that telehealth is here to stay, or that's what our assumption is. It can create efficiencies, it can create access. What is the right blend of mix between in-person and telehealth? And that's going to be different for different patients. So we have some patients with advanced dementia. They're not very communicative. Telehealth is just not going to work for them unless there's a really great caregiver who can really convey what's going on. There are other patients of our telehealth where it's great. right? It actually lets you see them more frequently than you otherwise would because there's no travel involved, or it can be set up very efficiently. And so we're banking on telehealth being able to be used for longitudinal care. We're actually in some of our clinical programs, we're providing patients with iPads, not necessarily iPads, so we shouldn't use that term, but a tablet for longitudinal care, because it makes more sense for us to just give it to them for their duration within the program. And then we're on the same platform. It's really easy to connect back and forth. And now from a technology side is how do you make it simple, effective, and really, a way for bidirectional communication in ways that really make sense for patients. But I think you can use it for a gamut of things, but there's no one rule.
Dr. Wibberly, anything to add?
Yeah, I would say, there are some things that are training in terms of provider training that would allow them to do a better physical exam than if you don't have the training. But, there are two main components to the physical exam. One is, being able to teach the patient or their caregiver to be your hands because you're not there to touch. And those are things that you can do. You can teach a patient how to palpate a certain area. You can demonstrate. You can ask them, how does this feel? So that, but part of that is learning how to say that in words and to demonstrate it in a way that the patient understands. But the second is, some things that do require some peripheral devices like a stethoscope, otoscope, and practices are now, as they're thinking of making this a sustainable long-term operation, starting to think about, how do I give access to my, a digital stethoscope, a digital otoscope to my patients. But part of it is that many patients do have devices at home, and so giving the provider kind of permission to use, to say, hey, do you have a blood pressure cuff at home? Why don't you bring that out here and let me watch you take your blood pressure, because a lot of times patients just need some instruction on how to take their blood pressure correctly. And so, that there are multiple ways to get around some of those, we don't have devices issue.
By the way, I want to point out I felt very comfortable when I did my telemedicine because the doctor was 10 minutes late, just like she always is when I'm there. By the way.
It's a good point, Kathy. If I could jump in,
Sure.
one of the things that we teach our customers is something called webside manner, right? It's how do you interact with your patient in a healthcare context. But Herb, to your point, PT is actually a really common use case for our customer visits. Maybe if the physical therapist is manipulating your body, no. But if they're teaching you the exercises, you want to bring your spouse in so they can also learn the exercises. You can have multiple people in a single visit. There's an application for pretty much every specialty at this point.
Well, for me, I'd have to try to get one of my laptops or something instead of so they see what I was doing. Because if you're doing the stretches on the floor, it's like this is not going to work. Situation. But it's going to get so common, Sarah, that people will eventually be able to use whatever little device they have. I don't know what Amazon's down the street, but the one where you can talk in the the screen or whatever the Amazon whatever that is. Will it be like whatever you have pretty soon? It won't have to be a laptop or a tablet, or it'll be however you visually communicate in the world you'll be able to use. Do you think?
I would expect it'll go in that direction. Yeah, I mean, even in the last year, the whole thing used to be apps. Everybody wants an app, but then you have to have the patient who can download the app. Do you know your Apple password? I don't know mine. So there are barriers to that. Our platform, for example, is we over the years switched from an app-based platform to one that was browser-based. So no matter what module you're on, as long as you're on a supported browser, the Amazon Fire, for example, we have folks using that tablet, which was started as like an e-reader. So yeah, I do think it'll go in that direction. It of course depends on the technology of the devices, but no one is talking about less access. That's for sure. I think that's the direction it'll go.
Can I jump in? The interesting thing about that is that I just heard about an emergency room that was using Amazon Shows because it was contactless, and patients who were in the ER, or in intensive care, could activate it with their voice and didn't have to touch anything. And I really do think that this is something that's coming for telehealth, because especially older Americans or very sick people cannot necessarily do all of the things we kind of take for granted. But the thing is, I think it's coming. I think it's going to happen, but I do think it will change a lot of very critical structures and data flows. So for example, I foresee many more companies becoming business associates under HIPAA that may not have ever considered that before. I see a lot of new cloud platforms that will become HIPAA compliant or, able to be used by healthcare providers without, having a risk of, getting their knuckles wrapped by the Department of Health and Human Services. That all is going to happen. And I have to tell you, that's going to require a significant change in the HIPAA rules. And that is going to be something that has to be grappled with probably within the next year, maybe next year and a half. It depends on how long the emergency health declarations are still in place. It's actually going to be, I don't think there is any disagreement that it will happen. It's just, I don't see how it will happen easily.
Yeah, and I think, we need to really think about, this has always been the case. Technology has always advanced way faster than policy. And so there are technologies out there that can allow you to do most of the things that we've just talked about, saying that this is difficult, but we don't have policy to support it, which is part of why it has not been used. So there are parts of Europe right now that are using hologram medicine, where you basically transport yourself in 3D image to a patient's room, to a patient's bedside. Those are like literally in use in some countries, whereas in the U.S. we have yet to see anything like that. And so it's really, a lot of our restrictions are policy based.
Well, that's cool.
Just one thing. I think that's great points, Pam and Kathy. I think but there's an intermediate stage, and I'll take the payer perspective here, between technology and policy, and I'll equate payment with policy right now, which is the data to suggest that this will actually derive the benefit you expect. So let's go with your home PT example. I think literally within the last 90 days, I've been pitched by about 5 to 10 companies that do home PT. And I've seen their wares, their technologies, their platforms, et cetera. One of the questions I have as a payer is, when I do PT or cardiac rehab, right, within a rehab facility, someone just had a heart attack or they have heart failure, I sort of know what I'm getting, right? If I'm going to pay X amount of dollars per session, there's an expected clinical benefit. It's good for patients, great. How do I measure the quality of someone doing virtual PT at home? What is the expected benefit of that? No one has ever studied that in the same rigorous way over many years that they have for in-office PT, all these other sort of older, less sexy technologies. And so I think what COVID has really done is really pushed a lot of these technologies to the forefront. But I think some of the data, when it comes down to actually paying for things, needs to catch up, because everybody knows healthcare costs are exploding in the US. The percentage of our GDP that goes to healthcare is obscene compared to the rest of the world. And so I think it's all great, but there needs to be that intermediate layer of data that then drives the payment and policy. And we're just not there yet.
Just to be a little bit of a devil's advocate on that one. So, how much of quality do we actually measure in terms of in-person care? If I go to one primary care provider and I go to 2 different ones, I'm going to get 3 different qualities of care. Nobody's standing there saying, hey, you're using your stethoscope. Have you had your hearing checked lately? Yet we hold a very different standard to telehealth care. And so, I realize that quality is an issue, but I also feel like we are holding telehealth to a little bit of a different standard than we do in-person care.
The other thought that I'd add is there's a little bit of a chicken and an egg, because when you have this ease of access, you may provide care differently. I mean, one of the things that you mentioned at the beginning, Kumar, is frequency, right? It's the number of times that you can see your provider without it being a terrible hassle for you, or filling up your provider schedule for something they may not be getting reimbursed for. So back to the PT, I mean, I broke my finger a couple of years ago. I had to go in and they showed me how to do my little exercises, and they wanted to see me every 30 days. It took half a day to go to the hospital and just show them, look, my finger's bending. and if I could have gone in, that was a 3-minute visit. And so you can have that, the quantity of touch points changes when you can do telehealth. And so there's there's some amount of we don't know until we know that it'll be interesting to see how it plays out.
Yeah, and just to respond, I agree with everyone's perspective. So I think for your finger example, certainly if you're looking at range of motion on a finger and that's what you were called in for, it made no sense for you to take a half day off from work to do that. And that's a problem.
No doubt.
It's very inefficient for families. And I think from a consumer perspective, I hate the term like the patient was non-adherent and things like that, because it's the patient and their caregiver taking a half day off from work for a 15-minute appointment that, Herb, you only waited 10 minutes for your doctor, right? I mean, people can wait hours sometimes for their doctor. It's just, it's poor quality, it's poor experience. So I get that. And so I think, I agree, and I think the quality too. Like we don't always know the quality of regular care, regular in-person care. But that being said, in many cases, we do have years of data on regular inpatient care in average producing an expected result. We don't have any of that with telehealth, and that's just whether we disagree or not. I can guarantee you that's a perspective payers have. And I think one of the key things that there's a gap is as people build technology and want to get it covered so that patients can have access to it. Oftentimes technology is built, and I've just seen this over the last few years, without actually thinking about what the payer cares about at the end of the day. And so it's like, here's the product at the end, and it's like, oh, but you didn't design it in a way that it's going to get covered. And I actually think that's a really important gap we need to bridge, so that when great technologies come out that really improve the lives of patients, we're already set up to get the pivotal data to say, like, of course we should cover this, right?
How do we deal with a situation where you have someone who needs to have someone else there helping them, a senior who doesn't know how to do the technology, somebody who maybe has dementia, can't comprehend what's going on? How do you, as the physician, there's the privacy implications for Pam, but let's start with the physicians first. How do you dealing with that? I mean, you have to make sure that the person says somehow I'm okay with my sister being here, or how do you work that scenario out? Dr. Wibberly, you want to start?
Yeah, sure. So it's really no different than in-person care. So, some patients come to the office and they bring 10 family members with them, and you basically ask them if they're comfortable with all these family members in the office. You document in your notes that you had, husband, wife, 6 kids in the room. I mean, I think there are some privacy, confidentiality issues, if you're talking about sexual health and things like that, where you will definitely want to have that privacy. But for the most part, as long as the patient is comfortable with having someone there and you document it and they acknowledge that they, want that person there, there's usually not an issue with that.
I agree with Kathy. I think a key thing to make it work is scheduling at a time when a family can be there. So, and that could create hassles to providers, right? It's a layer of complexity, right, in terms of trying to schedule patients in. But I think if your perspective is how do I deliver the most value to the patient, how do I make this the best possible interaction, you have to be willing to work that way. And then this is where it gets back to that policy, right? And we have to pay for value rather than just like churning through patients, and just RVUs and the traditional way that we pay in this country. But I think we have to be flexible, and we have to be willing to take the time to then educate. Maybe it's the caregiver to get them, because they're your key partner to get the telehealth appointment even going, right? And so sometimes there might be, even before the appointment, right, with the family member to get them there. But if we care about providing the most care for patients that's the highest quality, that investment makes a lot of sense. And sometimes it's a one-time investment that'll pay for, I don't mean financially pay, it'll yield clinical benefit to the patient for multiple telehealth visits in advance.
Dr.
I
Wibberly,
think it's actually one of the benefits of telehealth that we're finding, not only the number of missed appointments that gets decreased, but the ability to involve family members in care that might normally not have come to the visit with the patient, but because they're in the home, they're there. But I think, the other piece is the context of the home environment, where you don't see in the office. You get a lot of information about social determinants of health just by observing what's going on. Is there food in the refrigerator? The 98 beer bottles on the can, like all those things, pieces of information that you would not get if you were not kind of observing what's going on in the home environment and who's with them.
There's a couple of, actually one question came in. I wanted to respond to that and just make a quick comment. So when we're talking about HIPAA, HIPAA is an acronym, an evil acronym, sorry about that, but it basically stands for the health privacy law in the United States. It's what healthcare providers like doctors and hospitals and pharmacists will need to adhere to in order to protect their patients' privacy. In regards to the telehealth situation where there might be a lot of different people in the room, that actually can produce a problem with confidentiality legally. And it's a very delicate thing. And that's something else that is going to have to be worked out. But it's actually a really, really difficult thing in terms of the legal arguments about, patients who may have lost confidentiality privileges because a neighbor was in the house when they had their doctor's appointment, et cetera, et cetera. So we definitely have a whole lot of policy to work through in this new era. We're going to have to work through it. But I think that we're going to need some very, very thoughtful debate and discussion and solution finding on these issues.
Yeah, but they're not things that can't be overcome. I mean, I think there are things you develop in
like debate last night.
things that you develop in protocol, right? You ask these
Right.
questions before exam. Who else is in the room?
Right.
And you document it. Who else can hear you? I mean, all
That's
those
right.
things. Yeah.
I agree completely. And these are not insurmountable problems. We just need to surface them and begin to solve them one by one.
The way we handle it from a technology side are in some ways. Oh, sorry, Herb. Go ahead.
Go ahead.
It's your show.
No, go ahead.
I was going to say that from a technology perspective, at least as it applies to our platform, we handle it technologically, and our customers handle it operationally. We give patients. Patients are the only ones who can invite other people to their visit. From a technology standpoint, send them the link. The provider cannot send to two different people. It can only be the patient who sends that. Our healthcare compliance attorney reviews everything. Every single release goes through them. So that's how we maintain HIPAA standards. The operational component is many of our customers have schedulers, medical assistants, whoever that may be, get on with the patient before the visit begins. And so they orient them to what's going to happen, and they room the patient is effectively what's happening, and say, are you in a safe place? Can I hear you? Do you have any questions before we get started? Is anybody else around you that shouldn't be, to kind of make sure they understand what they're walking into in order to let them have the most successful visit possible. Now your turn, Herb.
Actually, for my provider, they sent emails and texts ahead of time. They called ahead of time to make sure that I knew my equipment was set up. And then when I signed on, a nurse or assistant got me briefed and said what was going on, make sure the sound worked, et cetera, and then said the doctor will be with you, sometime in the next 2 hours. But that worked out very well because they took care of all the technical stuff before that happened. Dr. Wibberly, I want to do a follow-up to you. You were talking about if the patient brought the whole family in on a trip to your office, you could see them. You would know what they were there. But what about the scenario that was just raised? You're talking to me, and you have no idea that Crinkle the Wonder Dog is over here. Listen to everything. You don't know who's in the room. You don't know what's going on. I mean, that does sort of raise some kind of, I don't know, how do you deal with that?
Yeah, so that's when you build into your protocols the handful of questions that you ask in advance before you start your visit. And really depending on what type of visit, if it's a mental health visit, we're much more careful about telling people, they need to ensure privacy. And so, you ask right up front, who else, is there anyone else in the room? Is there anyone who can hear? If it's an issue where there's potential domestic violence or child abuse, you can create a safe word before the visit by phone with the patient. So, you use the safe word if you feel like somebody else is in the room or in the vicinity, so that to stop talking about certain things. There are certain passphrases that you can also use. Some providers use something simple as like, did you go to Walmart today? And if the answer is yes, there's somebody in the room, let's not talk about anything confidential. So there are a lot of kind of best practices that we do on the training end to help providers deal with some of that confidentiality issues.
So when COVID goes away and we're sort of almost back to a normal kind of life, and the patient has the choice of going to the medical provider or the doctor's office or doing telemedicine. So, we're talking sometime late next year, maybe. Who is in control of whether it's a telemedicine visit? Is it going to be you, the medical facility, the doctor? Is it going to be me, the patient? Do I say I don't really want to schlep an hour in rush hour traffic to have you say, are you taking your meds? But I would like to see you when I'm doing my checkup to see if my arm still has who is going to be, how are we going to work that out? Because some people like the idea. I like seeing my doctor for certain things. We talk, we face to face, the contact. Telemedicine's great, but it's not the same as being there in the room with your doctor. Who's going to be the decider? Is it going to be insurance people who pay different rates of pay for certain things? I'll leave it open to anybody, but all of you, whatever. Who's going to be the decider of this? Okay, Sarah.
Who wants to take it? Across our customer base, it is all of those. It's all of the above. At the end of the day, if the patient isn't comfortable doing a telemedicine visit, they will not be doing a telemedicine visit. If the provider isn't offering telemedicine, the patient doesn't have the option. If the payer isn't paying for it, the provider may not be offering it. So it will be a combination of those, and a lot of it will be personal preference, but I think that will morph over time. I hope to never go into another office again for a prescription refill. I don't want to do it. I'm not getting examined. It's like, don't make me do this. So I think it will be, I think it's all of those together.
Yeah, I think that's right. And, we're definitely, the pandemic put us in a very interesting situation where it advanced us much more quickly into a digital first environment. And I think that that's put us squarely in a transition era or zone. So Herb, I don't think any of us have the answer for that, other than we're going to see those options be available more rapidly, maybe even by a decade, than they otherwise would have been. That's my guess, but I'm only guessing.
And there are going to be some things that are clinically driven. I mean, there are going to be some things that you're going to need to go in the office for, procedures and things like that. And so, I think, like Sarah said, it's going to be a combination of those things, but there will be some things where a provider will say, I need that patient in the office for this particular visit. And it always will come down to clinical judgment at some point on what you can do virtually, what you can't. And as technology becomes more ubiquitous and advanced, we'll probably be doing much more things that are outside the office, the whole hospital without walls kind of scenario. And so I think we're going to be seeing that shift as well.
So for our tech folks, here's my question. Any kind of technology, new technology that comes about sooner or later, and often it's sooner, gets co-opted by the criminals of the world. So how are the hackers and the criminals and all the bad people in the world going to use telemedicine to hurt us? Go ahead, Pam.
I'm going to take that one, Pam.
We're already seeing it. We've already gotten some stuff in. It's pretty ugly. So I think one of the first early ways that we're seeing are fake links coming from like name brand health plans for logging into your new telehealth platform. And it's just an absolute rip-roaring piece of malware that you install on your computer. So you just hate to see this kind of thing happen. I think this is also part of the curve. This is going to have to be built into everyone's procedures of, okay, when you hear from us, it's just like what banks have had to do with email. When you hear from us, we'll never ask you to do X, Y, or Z. I think we'll end up having to do that. I think that will be very helpful. But one thing that I would say is this. I would encourage all providers to never ask patients to text images of their health files or exact birth date and address and social security numbers and insurance card numbers to anyone. And that's one of the ways people are getting caught up in medical identity theft in this new environment.
But Pam, all the emails say, click this link to start your telemedicine conference. I mean, that's how you start them.
I know, but there's ways of doing it.
You know, that's why some people go to an app-based platform, because it's a lot safer, which is more complicated for the patients to use. But that's a whole, I mean, the key is you're going to have to click on a link to start your thing. You click on a Zoom link to start your Zoom. I mean, that's what the criminals exploit, and that's where we're moving people. So that's going to be a serious problem.
It will. There's no question about that. And we're going to have to do a lot of patient education around this. And we'll have to develop, hopefully, some technologies that will be assistive in solving these problems.
Because, you know, by the way, you're not to correct you, but the banks still do send things that say, click here to see your account, click here your transaction, click here to pay your bill. So I mean, this is so important, so sensitive. Maybe we need to do something that's more secure and get the patients to learn the security protocols, as opposed to making it simple so the bad guys can take advantage of that. Dr. Dharmarajan, do you have any thoughts on that?
Yeah, I mean, I think it is. I think you, Herb, you bring up everything is happening via short messages and links. I'm just thinking through this as we have this conversation. I think the real risk is if folks hack into EHRs, right? Because it's one thing to say, click this link for your telehealth visit when you're not scheduled for a telehealth visit that day or at that time. But if they get into the EHRs and understand, or wherever schedules are, right? Oh, sorry. Yeah, electronic health record. Yeah, you may have heard it may be called EMR, electronic medical record, but a repository of schedules, wherever that lives. That is potentially scary if someone gets into that and exploits the fact that they know when you're supposed to have a medical appointment with which person and pretend to be that person. I'm sure, Pam, it's already happening. You would be in the know, not because you're a criminal, of course, but you would just.
Plays a criminal.
Yeah, so I think I'm just sort of medical
criminally to solve it. Yeah.
So no, but I agree. I agree. Wherever there's an opportunity, someone's going to try and exploit it. I think there's probably a whole bunch of regulatory and other just sort of security systems and companies that are going to spring up to help prevent some of this. But that is kind of scary.
And that is the whole balance that we've been trying to struggle with. You know, HIPAA really tries to protect that, but then it creates a barrier to access because it makes it much more complicated for patients to navigate. And if you take out all those restrictions, you have the issue with, you know, hackers and other people trying to steal data and violate the privacy and security.
You know, I'm really glad that you brought up the electronic health records. You know, with the new kind of frictionless one-click access to download your record to your phone, we are very concerned that that's going to create a huge outflow of electronic health records to places they shouldn't be. So I think that's another really important consumer education piece that actually providers could help a lot with. If patients knew that when they download their health records to their own phones or their iPads, et cetera, if they knew that those records leave the protection of HIPAA or the health privacy rule, they may not choose to do that, or maybe they would do it more partially, or they may make different decisions. So I do think that there are really good opportunities for healthcare providers to do more education around that.
Sarah, since you're our tech person, I just wanted to get you to weigh in on the security versus the ease of access in the technology area.
Yeah, it's something that I encourage our customers, so practices, to be really intentional about when they are choosing which platform to work with. So for our part, we have taken an approach to, we've kind of tried to walk the line, right? Where we need to encourage ease of access, otherwise people won't use our product, but we cannot risk security. And so, for example, like I said, we're a web-based platform. There is no patient login. You click, you give your consent, and maybe the provider has intake questions, things like that. But there are all manner of cool things we want to do with our product that we won't do, because then we would need to put it behind a patient login, and then that restricts access. So for example, we have we integrate with several electronic health records, but we push data back into the EHR, electronic health record. We don't pull any out. So we don't even take the patient's name other than to schedule the visit. No information is presented to the patient that's coming from that EHR. So if somebody steals their phone and they click on a link, that thief won't get any medical information about that patient. They will just know that they have an appointment at a certain time, could be a haircut as far as they know. So it's a real balance that certainly on the vendor side we have to be really intentional about, but on the provider side as well, as they are choosing which vendors to work with, to be thoughtful about those things on behalf of their patients.
We've spoken about barriers based on age and based on mental capacity. Dr. Wibberly, want you to talk about another barrier, which is people have limited English abilities, and you're working with that, and that's a whole another area that we have to deal with. So could you talk a little bit about that, please?
Yeah, so it's both the limited English proficiency as well as those who are hard of hearing, and a lot of the kind of populations that need some kind of interpretation, and so video actually enables that very well if you're on a platform that can bring in multi-users. So you can bring in a sign language interpreter by video, you can bring in another language, but many times, because we did the rapid pivot to this, people had some of those things set up in the office, but did not have that set up by video platform. And so I think we're seeing people trying to figure this out now. But there really is no reason why you can't bring in the same interpreter that you would use in an in-office visit into a video conference visit.
Have you done that? Does it work?
Oh yeah, absolutely. It works very well, actually.
That's great. That's great. I was doing a story. I do a medical tip every week on the radio station, and I was talking to my doctor I've talked to for 17 years at the UC Berkeley Wellness Letter, and I said, do you have to get prepared for a telemedicine visit just like you do if you go to the doctor's office? Because it's so easy. You run at the last minute. You don't think about it. You sit in front of the monitor. And he said, yeah, you should. You got to. Could one of the docs talk about what you want patients to think about when they just sit in front of the camera?
Yeah, I mean, I think there's probably preparation on both the patient side and the provider side, right? So on the patient side, and I'm sure Kathy will have a lot to add to what I have to say, I think you want the environment to be just call it as calm as possible with the least amount of distraction. So if those distractions are a pet or other people, right, in the house, the neighbor, that example, right, that's a distraction with other implications, right? So I think you want that. I think you want it to be a comfortable environment, right? So if they're using a phone or a computer, an iPad, you want it set up right. And, it's like any procedure. That's the way I think about it. So, I'm a cardiologist as well as a geriatrician. My cardiology side, through my training, I did a ton of procedures. And the most important thing to procedural success is being set up for success, right? You don't want to be doing a procedure, this hypothetical, and be like, I'm missing this instrument, right? Or the patient is set up in the wrong position. I think it's the same thing here. It's comfortable. They can see you. The thing, the device is set up in a way that's easy. So they're not managing the device. They should really be having a conversation through the device, and the device should be an enabler, not an impediment to that. And then I think on the provider side, you got to be professional, right? It's so easy not to be here in the same way that you might be in the office, right? Whether it's being kept, like not having, and one thing we haven't talked about, and this is a real challenge, just like everybody's at home and working through the struggles of that. I have my 3-year-old here. I was in a call earlier today. My 3-year-old jumped in my lap. I love my 3-year-old, but it was, it's one of those things, right? And so you're trying to manage all that. Now imagine that happening and you're having a very, private conversation with a patient. Some people might love that and seeing a little child who's cute, but others might not, right? And so I think it's a challenge on both ends now because we're often doing telehealth from environments that we didn't do telehealth before. Maybe we went into a telehealth office, or we're doing it from home. I'm doing this from home. I think so attention to the detail and prepping yourself to make sure the school is being attended to, the other things, at least you're doing your best to set yourself up for success. and to have an encounter that is professional from the perception of a patient.
Dr. Wibberly?
Yeah, we have a lot of checklists that we actually offer on our website, that are how to prepare for a visit kind of checklists, and a lot of the things that Kumar mentioned. But we they're some of those are very simple things, like make sure you plug in your device because you don't want to run out of battery 10 minutes into your visit. But the lighting is a really important thing, because for a clinician to be able to really like look at your pupil or whatever, you need some kind of light source. And so even having a flashlight around is oftentimes useful for an exam. But very basic things that you would actually tell a patient to do in the office, but you oftentimes forget to tell them when you're doing a video visit, are things like write down a list of questions that you might have so that you're prepared. You're not trying to think of them on the spot. But things like, putting a do not disturb sign on the door if you're in a private room. And that's the same for the provider, so that all the family members don't go traipsing in at the time when you're having a visit. But there's nothing that's really like crazy preparation, but just kind of what we would call common sense, because we're used to doing video, but someone who's not probably would not consider it common sense. So just, things like, set your device on something stable so you're not walking around with it. I mean, things like that.
That was, by the way, the number one tip my doctor gave me, is write your questions down, because once you get into it, you're gonna lose your train of thought. You're gonna get nervous if you haven't done it before. But if you have the questions, just like you would write it down if you went to the doctor's office, you should have some questions. Here's a technology question. Maybe Sarah wants to jump in on this. We all know that technology is wonderful when it works and is not wonderful when it doesn't work. So what happens if you're in the middle of a telemed check with your doctor and it just doesn't, I mean, it's buffering, you can't hear, there's no audio, is there a protocol? Does somebody from the doctor's office or the hospital call you right back and say, let's jump on the phone and get this taken care of now, let's reschedule? Like my hot tub guy just said, well, we'll do it from 2 weeks from now because I couldn't fix it today. How do you deal with the inevitable that the technology is not always going to work?
Yeah, absolutely. And it does happen all the time. We got a support call a couple weeks ago about a group that the visit failed out. What happened? We were doing some root cause analysis. It turns out that the patient was standing in a literal cornfield. And I'm from Indiana, so I can I can bring that up as an example. Not great bandwidth in the middle of rural Indiana. So yeah, it happens all the time. There are all manner of variables that the provider cannot control. And so something we do on the technology side, for example, is the way that we built our platform. When bandwidth starts to decrease, we just drop out video and audio stays. And so that really allows the practice to determine what operational steps they want to put in place. Do they at that point say like, hey, this is challenging, I'm going to drop and call your cell phone, is this the right number? Maybe they decide to reschedule. My best guess is it goes to phone call for most of our groups. But it is in some ways practice preference. In most cases, they're going to try to complete the visit in one way or another.
And I think it's key that the provider take their technology side seriously. I mean, Dr. Wibberly, you got the headset on, you can hear you clearly. If it's not clear, if you don't have good lighting, if you're not in a good background, if buy a USB microphone for $85 and make sure you're talking, or a headset so the person can understand you. I mean, if you guys on your end, the provider's end, you've got to take that every bit as seriously as the patient has to take it on their end, right?
Yeah, absolutely.
I think that's a transitional state that we're in right now. We were all forced back into our homes, and nobody has their home office with a stately background set up unless that's something that they had pre-pandemic. And now you see more doctors wearing their lab coats and they've got their background or a virtual background, whatever that is. This is now normal, and we're figuring out what our standards are for that.
But it's okay.
An interesting thing people are facing right now is because people have kids at home and everyone's working at home, and you've got sometimes two adults working at home. It's taxing the bandwidth more than people thought. And so you've got 3 kids on Zoom meetings at school doing virtual school, and 2 adults working from home, and all of a sudden what worked really well 3 months ago when kids weren't in school is not working now, and they need to do something to fix that.
As I was saying, Sarah, you're allowed to wear sweatpants, right? That's okay as long as it's below the camera line.
Sure, do whatever you want. As long as it's below the camera, we don't care.
There's a question that came in from someone, from an attendee, that said that some one-bedroom homes may have lots of people living there and nowhere for privacy except maybe a bathroom. And yes, that's absolutely the case. And I would add some apartments, you can hear through the walls. So these are all considerations that are new and fresh and will have to be managed. You know, the other consideration is, you know, for the very popular apps that are more commercial and more social media oriented, you know, I haven't yet heard of someone who's clicked on a broadcast link while they're on a physician phone call, but I assume that is going to happen one of these days. And so I would just, I just think that whatever technology is devised and that we encounter, we need to make sure that it's so simple that we never broadcast to social media. Like I couldn't even imagine doing an Instagram accidental live with, you know, a physician appointment going on. Oh, it would just mind-boggling there.
How could that happen? What would be the scenario?
Well, it would be a missed link or a person within the house doing it. There are all sorts of scenarios for mischief, and it's another aspect of what we have to be careful of in this new protocol that we're experiencing. I do think all of these things can be solved, but I also think that we really need to be cautious about doing any of these appointments in a public space where people who do not know you can just simply, you know, post things to social media. The patient out in a cornfield, that would be totally fine. The corn will
totally private.
I assume that
we do see a lot of patients having visits from their cars. That's a pretty common, pretty common location.
We've also seen issues where part of your protocol and your consent documents are, we're not going to record this visit, neither you or I, because, you know, if you're using something like Zoom, I mean, a patient can go and, you know, record the visit.
Right.
I assume that some people will be forced to use Wi-Fi hotspots to do this. And I assume the same rules would apply, that just like you wouldn't do your banking on a Wi-Fi hotspot, you wouldn't do your telemedicine call on a Wi-Fi hotspot.
Sometimes you don't have too much choice. If you don't have Wi-Fi at home and you don't have internet access at home, and your only way of getting care is to use a public Wi-Fi hotspot, I mean, it's not recommended. It certainly has a lot of risks, but unfortunately, for some people, that's their only alternative.
Pam?
Yes, that's unfortunately true. You know, and the other thing, we haven't really touched on it very much, but there really is a poverty issue here. It's not spoken of a lot, even in privacy circles, but, you know, people who are working on feature phones that are not smartphones are particularly vulnerable in this situation, and may have to go into public libraries and other spots where they can have access to the internet in ways that definitely expose them to more eyeballs, as it were, and less privacy. There's definitely a digital divide, and it's of great concern. It should really concern all of us.
So is there a need for, and I'll open this up to anybody, is there a need for medical providers, for insurance companies, for nonprofits, the Bill Gates Foundation, whatever, to start making sure that people have the technology that they need if they're going to start if we're going to take telemedicine seriously? Doesn't work.
and the broadband, yes.
Yeah.
I think it's three. It's hardware, it's the connectivity, which is broadband, et cetera, Wi-Fi, LTE, and it's also education, and it's a comfort and familiarity. And so, if we could provide everyone with hardware and broadband, that would get us a lot of the way. But I think whether it's language or education or age, there could be barriers for various groups even beyond the hardware and the connectivity. And I think you're seeing that. You know, I think Sarah's example of a payer providing iPads, like we're doing the same thing. We're literally, we call it our Video on Wheels program. It's sort of it's a pilot, right? But we're literally delivering devices for visits and then recovering right at the end of the visit. The person will be there at the end, sort of like white glove service. It's people who don't have hardware and connectivity. For some of them, we have these really great stories. They're not used to someone delivering something like that so that they can have a visit with a provider. We had this great story of an older man who said, this was great. I've never done this before. I really need to get an iPad so I can video chat with my girlfriend, right? And so there's some of these really great stories, but it's hard to do that. It's not a real scalable strategy in the same way as just delivering, recovering, but it's better than nothing. We've also started trying to ship things, right? The issue with shipping a device is, and more people are doing that. It seems like easier to do than physically delivering it. The device has to arrive on time. It has to be taken out of these seem like little things, but they have to be taken out of the box. They may need to be charged. They need to be set up. And where it gets harder from the provider side is if you book people for appointments and it fails at any of those steps, and then there's no one there when you have time to deliver care, it's a problem if that happens too often. So, which is why we're just physically delivering them in various geo areas around the country. But I think that it's ripe for smarter approaches than that, and literally getting people access. But I think the good thing here is it's cheaper and cheaper, both the technology, and so I'm hopeful. And the U.S., I gotta say, in certain respects, is behind. There are countries around the world with much lower economic resources, GDP per capita, however you're looking at it, where smartphones are in the hand of a much larger population of patients. So we have the resources in the country. I think it's really about commitment rather than resources.
Yeah, and I was going to say we've heard some really interesting kind of creative solutions of people using rideshare services like Uber and Shipt to come pick up the iPad from our office, bring it to the patient, and then bring it back to our office when the visit is done. I mean, we've heard people doing things like that.
I read an article a couple of months ago, so it might be outdated, but I was saving it because I knew this was coming up, that indicated that insurance companies were very eager to do telemedicine when COVID started. Excuse me. And now that there's some pushback, there's some resistance, they're not sure if they really want to go in this direction. Is that correct? Can anybody give me any update on that, or where we stand with how insurance companies feel about doing this?
I think that's probably a general statement. I think it depends on the company and the market, right? I think probably so I can talk about our experience. So there was a time where 80 to 90% of our visits were telehealth for a 3 to 4 month period, March, April, May, June. Right now, we're at about, depending on market, about 60 to 80% back person to person. It depends, right? That we have areas around the country with still very high COVID rates and others that are much better. And so, I think probably payers, what they're wondering about there is, I think it comes back to this, and Kathy, I know what you're going to say, right? How do you know the quality about face-to-face visits in person? And it's true. But the question is, what are you getting? Is it necessary? I think the really big picture here that I think telehealth has shown and just COVID has shown, there's probably been a lot of discretionary care going on that is maybe not necessary. So Sarah, you going in for someone to stare at your finger and manipulate it for 30 seconds, right? Or, if you've ever been asked just come in, so you can get a prescription, Sarah, that was another example that you gave, right? Maybe especially if there's a chronic, someone's blood pressure, they have a machine at home, you don't necessarily need to go into the office for me to refill your blood pressure medicines. And so I think really the sweet spot there is, what is the right use of telehealth? Because I think pretty much every payer believes that there are niches that could be small or bigger where it's absolutely the right way to go. It's inherently less expensive. It inherently provides higher member experience of care because they're not schlepping for someone to stare at their finger for 30 seconds, right? And so I think it comes down to those details as to where are the right areas to do it. Because I think 100% of people realize through this COVID era that there are some right areas that are ripe for more telemedicine.
And as sensors get better, I mean, the last consumer electronics show I went to, which was last year, I mean, there are medical grade sensors that are moving into the consumer market, you know, oximeters, you know, all sorts of things that used to be you would find in a clinic, you can purchase as a consumer. And I think as that continues, that trend continues, that also will have an effect on how well and kind of what are the use cases that are best utilized for telehealth. I think that will change it over time as well.
Yeah, and I would go with, the remote monitoring movement, I think is going to be a big piece for chronic disease management. Where right now we have kind of episodic care, come back every 3 months, every 6 months, we'll recheck your blood pressure, check your meds. If we're monitoring their blood pressure remotely, where we're monitoring their, weight gain and knowing, when there's water retention and those things, we probably don't need to have them come into the office every 3 months, 6 months, 9 months. We can do an annual visit, or we can just do a wellness check by video because we know what their trend lines are. We know what's going on.
Yeah.
Oh, I'll share a personal story. I had a situation where I wanted to see I needed to see a rheumatologist at my medical center. And it was something where really it was just a question of med control. My GP was turning me over to a rheumatologist. And no one, not a single rheumatologist at the medical center I go to in Seattle, a very big place, would see me telemedicine. I had to have my first appointment in person. I mean, and it was still COVID time. And it's like, I don't really want to schlep there and be there when all you're going to do is say, take this many mgs of the drug, and I couldn't find a single doctor in my program who would, and it really upset me. It's like, and I went in and there was nothing that was done. I wasn't doing anything except here's what you need. It's interesting that sometimes there's certain, I don't know, is it a difference where doctors push back on a new patient, a first meeting, that they wouldn't want to see you telemedicine?
I think it depends, right? So I thought where you were going to go with the rheumatology example is there are cases in rheumatology where someone really has to examine your joints, your bones, your range of motion. They literally look for heat in your finger, in certain joints, and how swollen it is. And so I would think, I'm not going to delve into your medical history, but there are cases where rheumatologists seeing a patient in person would be, in my opinion, more effective, but there might be others where they're not, right? And so I also think, this seemed like maybe that was early in COVID. The world has changed. I wonder now if that would be the same. What used to, like, business deals where people would, jet across the world for a 1-hour meeting to, conduct business, right, and get that deal done and this and that. Those are happening by Zoom now, right? So, I think so. I wonder if your experience would be different now. I would hope it would be. And then, someone could give you a first visit, and then I'd hope that doctor or other provider would be able to say, in your case, this first visit, we were fine doing this telehealth. I have the information I need. But, based on what you told me, I really need to be able to examine you to give you the right clinical decision. For you, I need to bring you in, and we could be a little bit more nuanced about it than just yes or no and things like that.
Right.
So.
And we are on telemedicine now, and it's funny because when I went there, it was literally what we could have done over the telemedicine. So how many milligrams you take, and here's what I'm going to do. What's your pain level, 1 or 2? Thank you, goodbye. And so it's interesting because it upset me, because why did I have to take the chance and risk? I'm in the high risk group. Why do I have to to go do that thing? I'm going to go round robin and just ask you as we get close to wrapping things up. And you can take a minute or two. What you want, something you would like to share with the folks watching, something you want to let them know about telemedicine, where it's going, how to use it. You can talk to the provider side or the patient side or both, whatever. So just want to have you just share some thoughts. And I want to start with Sarah, because we'll get you'll done, then you can relax the rest of the time.
Okay. One of the things that I've thought of a couple times throughout this panel is how rapidly our customers are providers, but their customers are patients, right? And so customers' demand for us has shifted enormously in the last year, because I was CEO of a startup before, we got acquired, and poof, here we are in COVID. one of the things that used to be a differentiator for us was how easy it was for the patient to get in. You don't have to download an app. There's no username and password. And now we are getting pushback about it being cumbersome because of the consent policies that you have to, there's HIPAA compliance. You have to have patients who consent. And that is being driven by patients, by access, by relaxed requirements, maybe. So we'll see if some of that swings back. But I think the message that I would have for the audience is you have a lot of power, you have a lot of influence, and make your opinions known. Now, there's a lot of moving pieces to this. There's policy, there's providers, there's vendors, there's a whole show. But I think that the consumer will really drive the agenda here in a way that I don't think consumers have had that effect in healthcare before. And so I think pay attention to what you like and make your opinion known would be my closing thought.
And after your appointment, fill out your Yelp form and let them know what you think about it.
Yeah, that's right. That's right.
Dr. Wibberly?
I think I would make my pitch to providers, because that's who really I work with most on the technical assistance side. So, I think right now we talk about telehealth as if it's new, and it really isn't. Literally has been around for 30 years. There are a lot of best practices. There's been a lot of research. There are a lot of use cases that people have not been willing to try, even though people 20 years ago have tried it. And so I would say, if you think this is new and that you're in this boat alone, kind of trying to figure it out, you're not. There really are a lot of best practices out there. And so, telehealth resource centers are there to kind of help you with that. We are federally funded. We no charge. So please reach out, and we love to kind of increase fix what I call fixing sloppy. I think a lot of people who pivoted to telehealth really quickly in those 2-3 months of the pandemic did so just out of desperation, like I need to be able to see my patients and I need to have a paycheck come in. And so, now that you have a few months of kind of practice under your belt, go ahead and start working on the best practices so that it becomes a sustainable piece of your business model.
Great. Pam, I'm running late, so I'm going to give you 60 seconds.
Okay, so I think what I would say is first to patients that, if you're afraid of this, there's not a need to be afraid. However, just be cautious. Make sure that when you're in a communication with a healthcare provider, make sure that it's just you and the healthcare provider. I think that's actually really important. Make sure you're comfortable with the privacy of your situation wherever you are on your end of things. In terms of the rules around telehealth, my pitch would be to all of the providers and also to policymakers who are having to make these decisions. We are going to have to grapple with how to make this permanent. It's not going to happen automatically. HIPAA will have to be changed in some way to allow this to happen. We're going to have to find careful and thoughtful ways of doing it. And hopefully by then we'll have some data. But I think that we should start having the conversation now and not wait for a year or so.
And finally, Dr. Dharmarajan.
So I think my main message is to folks a little bit like Sarah in terms of this is a really important time to influence the rules of the game around telehealth. And to me, telehealth, at the end of the day, it provides a lot, but it's really an access. It's an access issue, access to telehealth. And we know that COVID may come back. There may be other things. And even in a COVID-free world, we want people to have the flexibility to receive the care they need that's the right care for them. And so there's a lot of policy associated with this that has been relaxed during COVID. Pam has mentioned, using a greater number of platforms to be able to access telehealth, things that you're familiar with already, or policy around what doctors get paid, right? So right now they get paid less to make a phone call than to do video. And I agree video can be higher quality, but if you're someone without smart devices, phone is all you can do potentially in many cases, and you don't want our system to create a disincentive for you to be served. And so I think this is a really important time to pay attention to these issues. And if telehealth has been helpful to you, whether it's by a phone call, a video system, et cetera, this is your time to let the folks in power know that, because we're in a situation of great flux, I think, around rulemaking here, and your voice really matters. And if it's really about your health, your access, it's your stories that at the end of the day matter in terms of swaying the day, whether it's with your congressperson, your senator, private payers, companies in the space, your individual stories matter.
Great. Well, I want to thank Pam and Sarah and Kumar and Kathy. Excellent panelists, great discussion. I sure hope the folks watching learned something. I certainly know I did. We're going to take a brief 5-minute break before starting the Consumer Excellence Awards, so you can grab a refreshment, you can run to the restroom, call your doctor, and we'll head right back here, begin the program right at 3 Eastern time. So thank you again, everyone, and have a great day.
Thanks, Herb.
Thanks all.
Thanks.